Hello, I'm Dr. Rich Brown, Professor of Family Medicine with the University of Wisconsin School of Medicine and Public Health, and Director of WIFL, the Wisconsin Initiative to Promote Healthy Lifestyles. You already know how important it is to integrate routine cancer screening into your practice, so we recognize cancers as early as possible when they're most treatable. What I'd like to talk with you about today is integrating alcohol screening and intervention into cancer screening so we can actually prevent many cancers from getting started in the first place.
Here is what we'll be focusing on. First of all, how drinking can increase the risk of cancer. We'll focus on a drinking continuum from abstinence to dependence. Then we'll talk about how screening and assessment can help you place patients on that continuum, which then guides what services patients would perhaps benefit from, either intervention or referral. And then we'll talk about practical issues of integrating alcohol and cancer screening into busy clinical settings. So first, let's focus on alcohol and cancer risk. This slide focuses on parts of the body for which cancer risk is increased by excessive drinking. You can see there are 7 sites where cancer risk is increased from alcohol. How much risk does alcohol pose for cancer? Epidemiologists answer that kind of question with 2 numbers, relative risk and attributable risk. Relative risk tells us how the incidence of cancer in people who drink compares to the incidence of cancer in people who don't drink. If alcohol conferred no risk, then the risks of cancer in the numerator and denominator would be the same, and relative risk would be 1. Attributable risk tells us the proportion of people with cancer whose cancer is likely related to their drinking. If alcohol conferred no risk, then the attributable risk would be 0. The next slide shows us the relative and attributable risks of alcohol consumption for each kind of cancer. For the top 4 cancers in the table, you can see that there's an increase in relative risk from 9 to 24% for each drink per day. So, for example, for women who have 2 drinks per day on average, their risk of breast cancer would be 20% higher than women who do not drink at all. This is the kind of information that many patients are unaware of and might prompt them to reevaluate their drinking. Attributable risk of drinking varies quite a bit across these cancers, as little as 2 to 6% for breast cancer, up to as high as 60% for cancers of the mouth, pharynx, and larynx. Alcohol is a fairly strong risk factor for esophageal cancer. Any drinking increases the risk more than 3 times above that for a non-drinker, and over 70% of cases of esophageal cancer are related to drinking. So, even a little bit of alcohol could give rise to cancer in a small number of individuals. Of course, cancer risk should not be the sole determinant of our recommendations to patients on healthy and unhealthy levels of drinking. Up to 2 standard drinks a day for men and up to 1 standard drink a day for women reduce the risk of cardiovascular disease. More than this actually increases the risk of cardiovascular disease above the risk for individuals who don't drink at all. Taking that into account, the American Cancer Society recommends that individuals drink no more than the amount of alcohol that provides some protection from cardiovascular disease. No more than 2 a day for men and 1 a day for women. And if patients not only drink alcohol in a risky way but also use tobacco, the cancer risk is even further increased. This slide shows a timeline from birth to death, assuming that someone is going to get cancer. Initially, there are risk exposures, where individuals are exposed to various risk factors for cancer. At some point, there may be transformation when a cancer starts to grow, and initially that cancer is typically highly treatable, but then may become less treatable over time, and at some point may become fatal. You can see that cancer screening is helpful in identifying cancers when they are treatable, preferably when they're highly treatable. We like to identify cancer as early as possible when cancer is most treatable. Typically, primary care practices focus on identifying cancers as early as possible through screening, but in this presentation, we emphasize primary prevention. preventing cancers from starting in the first place. By screening and intervening for risky drinking, we can actually prevent some cancers from starting. Next, we'll focus on the drinking continuum. You can see there is a continuum of drinking all the way from abstinence to heavy drinking. You can see that the more someone drinks, the more risks they have, and eventually the more numerous and severe consequences they accumulate. High-risk drinking is defined in terms of standard drinks. It turns out that 12 ounces of beer has the same amount of alcohol as 5 ounces of wine, or 1.5 ounces of 80-proof liquor, such as typical vodka or whiskey. The National Institute on Alcohol Abuse and Alcoholism has reviewed literally hundreds of studies to identify how much alcohol starts to put individuals at risk for health and social consequences of their drinking. You can see that when men drink more than 14 drinks in a week, or more than 4 drinks on any particular occasion, we start to see higher risk for those health and social consequences. When women drink more than 7 drinks per week, or more than 3 per occasion, we start to see elevated risk. The numbers are lower for women because they tend to weigh less, they tend to have proportionately less water weight in their bodies, and they tend to absorb alcohol more completely and quickly from their stomachs. You can see that when frail elderly patients have more than even 1 drink on an occasion, they may be at increased risk for problems with memory and falls. Now let's talk about the negative consequences that individuals can suffer from alcohol. Those consequences tend to fall in 8 different categories. There are many biomedical consequences that can occur from excessive drinking, but the first consequences in many people's lives occur in the realm of mental health. When alcohol use leads to mental health symptoms, those symptoms can negatively impact family and other relationships. There may also be difficulties at work or school. There may be financial stressors because individuals may spend more on alcohol and related activities than they can afford. There may be legal consequences. And for individuals for whom religion and spirituality is important, alcohol can sometimes interfere. So those are the kinds of negative consequences that we see in many individuals who drink excessively. Now let's look at another aspect of the continuum, dependence symptoms. In many, but not all individuals who are dependent on alcohol, we may see physical dependence, which means that an individual has had alcohol frequently enough, in large enough quantities, that when they suddenly quit or cut down, they can suffer withdrawal symptoms. This is very serious for alcohol because alcohol withdrawal can be fatal. Physical dependence is placed at the bottom of the slide because we now know that it occurs in a different part of the brain from where true addiction occurs. True addiction can involve preoccupation, where individuals have a hard time not thinking about drinking. Alcoholism can involve compulsive use, where a little drinking inevitably leads to more drinking, where 1 or 2 drinks can inevitably lead to 4, 6, or more. The most important symptom of alcohol dependence is loss of control, where try as individuals might, and some try very hard, they cannot consistently stay quit or cut down. We now know that addiction, including alcoholism, involves a hijacking of the pleasure-reward system of the brain. This is the system that nature gave humans and all animals to drive survival and procreation behaviors. This is the part of the brain that makes us feel good when we've had a nice meal. It's the part of the brain that makes us feel good when we have sex. And with enough exposure to alcohol over enough time, this system can get hijacked so it's driving drinking behaviors rather than or instead of eating and sex. We now know that the primary risk factor for alcoholism is genetic. Up to 60% of alcoholism is determined by one's genes. This slide will show 3 PET scans of individuals who are or are not addicted to methamphetamine. We would see the same PET scans in individuals who are addicted to other substances, including alcohol. This first slide shows the PET scan of a pleasure-reward center for an individual who is not addicted. The red area shows the greatest amount of nerve conduction. the amount that's necessary for a normal pleasure-reward system to tell the rest of the brain that life is okay. The second PET scan shows a pleasure-reward system of an individual who is addicted to methamphetamine but has not used any meth for a month. The meth is long gone from the brain and the bloodstream. This is a pleasure-reward system that is screaming to the rest of the brain that something feels very wrong, that this individual is miserable, and the only way to feel more normal is to use meth again. This is what's responsible for the urges and cravings, the compulsive use, and the preoccupation of addiction. The third PET scan shows the same individual 2 years later after 2 years of abstinence from methamphetamine. You can see that the red is coming back, the brain is healed, and the urges and cravings now are much reduced, and it's easier for the individual to stay clean and sober. These PET scans show that addiction, including alcoholism, is clearly a disease of the brain, a physiologic dysfunction of the pleasure-reward system. The good news is that when people stay clean and sober, often with help from treatment, we can help the brain heal and make it easier for individuals to live without their substances. The physiologic nature of alcohol dependence and the strong genetic contribution should remind us to be compassionate toward our alcohol-dependent patients rather than judgmental. About 5% of primary care patients fall into the category of alcoholism or addiction. These individuals do best if they can obtain specialty-based treatment. There are many more individuals in a middle category of high risk or problems who are not addicted or alcoholic. And these individuals can do very well by receiving brief interventions in primary care settings. Later in the presentation, we'll talk more about those brief interventions. Next, we'll talk about why it makes sense to screen all patients in primary care settings. Most patients who would benefit from intervention or treatment are not identifiable just by looking at them or their medical records. Most look like you and me. They have decent jobs, intact families, and we can only identify them by proactive screening. In Wisconsin, about 1 in 4 adults engages in risky drinking at least once a month, and about 4% are alcohol dependent. This high prevalence of risky or problem drinking makes screening very worthwhile. Furthermore, risky and problem drinking brings with it a high burden of death, injury, and illness. 80,000 Americans die every year because of their drinking. Alcohol use is responsible for over $200 billion of economic losses per year. Systematic screening can help us address these issues. Another reason to screen is that brief interventions can be very effective for many individuals, and sometimes perhaps even head off more serious alcohol problems. Over primary care populations, brief interventions can reduce risky drinking by about 20%. When we do that, we decrease emergency department visits by 20%, hospital admissions by 37%, injuries by a third, and arrests and car crashes by about half. Imagine if we could multiply all of these benefits across 1/4 of the adult patient population in Wisconsin that engages in risky drinking. This would be tremendously helpful to many of our patients, their families, and our communities. We also know that brief interventions reduce healthcare costs. One randomized controlled trial conducted in Wisconsin primary care settings found nearly $1,000 in net savings over the next year. Most of those savings accrued because of reductions in emergency department visits and hospitalizations, and those savings persisted at least through 4 years. Another study was conducted in emergency departments and trauma centers on patients who were there for alcohol-related injuries. Those who received brief interventions manifested more than a 45% reduction in repeat alcohol-related injuries over the next year. And in both studies, we saved about $4 in the next year for every dollar we initially spent providing services. A third study was conducted at Washington State emergency departments and focused particularly on dual-eligible patients, those covered by Medicare and Medicaid. That study showed more than a $4,000 reduction in healthcare costs per patient over the next year. So brief interventions can not only improve patient health outcomes, but also reduce healthcare costs. The United States Preventive Services Task Force recommends that all patients receive alcohol screening and intervention in primary care settings. Since 1996, the United States Preventive Services Task Force has recommended that all primary care patients undergo alcohol screening and, if appropriate, intervention. This task force recommends about 25 preventive services for individuals of various age and gender groups. The National Commission on Prevention Priorities was asked to rank preventive services in two ways. One is how much disease, injury, and death would be prevented if each service were actually delivered to the appropriate patients. They also assessed how much money could be saved if appropriate patients got the services. You can see the number one service was recommending daily aspirin for patients at risk for heart attack and stroke. This received the highest rating for preventable burden and return on investment. Number two was childhood immunizations. Numbers 3 and 4 were tobacco and alcohol screening and intervention. Those services were ranked higher than many other services that we've come to expect in primary care settings. Indeed, if we are going to screen patients for high blood pressure, cholesterol, and many cancers, it only makes sense to administer routine tobacco and alcohol screening and intervention as well. Here's just a small group of national and statewide organizations that recommend that all patients get alcohol screening and intervention. The National Business Group on Health represents employers. Employers are implored to make sure that their payers reimburse for these services and that their providers deliver these services. The Office of National Drug Control Policy is better known as the Drug Czar's Office, as these kinds of services can also be useful for various illicit drugs and misuse of potentially addictive prescription drugs. Two groups of employers, represented by the Business Healthcare Group and the Alliance, recommend that patients in Wisconsin receive these services. And you can see that other business interests represented by Wisconsin Manufacturers and Commerce agree. The services are also supported by the Wisconsin Medical Society and the Wisconsin Primary Healthcare Association, the umbrella organization for Wisconsin's federally qualified health centers. So now let's talk about proactive alcohol screening and brief assessment, which helps us place patients in various categories of drinking. We start off with a simple alcohol screening question. For men, we ask, when is the last time you had more than 4 standard drinks? For women, 3 standard drinks. Any response within the last 3 months is considered a positive screen. If the screen is negative, we want to reinforce good, healthy, low-risk drinking behaviors. For example, we might let patients know that 1 or 2 drinks a day for a man or 1 drink a day for a woman reduces the risk of heart disease and stroke, but more than that is actually unhealthy. And we want to commend patients for drinking in a healthy range. If that initial alcohol screening question is positive, then we need to know exactly which category the patient falls into, and that should prompt more assessment questions. So the goal of assessment is to more definitively categorize a patient's drinking so that we know which clinical service we should be delivering. In a low-risk range, again, we want to reinforce those good low-risk healthy behaviors. Patients who fall into a high-risk problem range, but who do not appear to be alcohol dependent, should receive a brief intervention. And those who may be dependent should be referred for more specialty-based assessment and possibly treatment. There are 2 different ways that we can conduct assessment. One is by clinical interview, and the other is by administering a brief questionnaire. When we conduct a clinical interview for assessment purposes, we initially attempt to identify negative consequences of drinking in these 8 categories. Subsequent questions can focus on whether there are dependent symptoms. More information on brief assessment is more than we have time for in this presentation. I'll focus especially on conducting brief assessment by a questionnaire. The questionnaire that's used most widely is called the AUDIT, or the Alcohol Use Disorders Identification Test. This test includes 10 items or questions, 3 which focus on the quantity and frequency of alcohol use, 3 on symptoms of dependence, and 4 on negative consequences. Here's a summary of the focuses of those 10 items of the audit. You can see that these questions focus on a wide range of behaviors and consequences and symptoms around alcohol use. The audit is quite easy to score. Each item is a multiple choice question, and each response can earn 0 to 4 points. You simply add up the points for the questions, and that guides the interpretation. 0 to 7 points puts a patient in the low risk category, and we want to reinforce those low risk healthy drinking behaviors. 8 to 19 points puts the patient in the middle range, where they would benefit from a brief intervention. And 20 points or more indicates possible alcohol dependence and referral for assessment. Next, let's talk about alcohol intervention and referral. Here are 5 recommended steps for delivering interventions or referrals. Initially, we give feedback and education about risks and consequences. Next, we make a recommendation as to quantity and frequency of drinking. Next, we make a recommendation, which could be referral or could be an adjustment in one's drinking pattern. If patients don't accept that recommendation, we may negotiate. Perhaps there's some amount that they are willing to change. And finally, we help the patient set a concrete plan. One way to give feedback is initially just to list the possible alcohol-related consequences without mentioning the linkage to alcohol. Next, we could express concern that perhaps alcohol is contributing to some of those risks and consequences. And next, most importantly, we ask patients what they think. In order to avoid arguments, it's important to avoid unilateral pronouncements. We certainly avoid labels. We might delay making diagnoses, even though we might be confident that the patient has an alcohol use disorder. The goal is to elicit discussion from the patient about whether there might be risk or consequences. Next, we may need to provide some education. For example, patients may not know that alcohol can contribute to fatigue because it impairs deep restorative sleep. Or patients may not understand that alcohol can irritate their stomachs or increase risk for cancer. Again, after delivering such information, we want to ask the patient what they think, elicit their response, and engage in discussion rather than making unilateral pronouncements. Often it's best to precede education by asking the patient's permission to share our perceptions or our information, so we make sure patients are receptive. It's very important when we deliver this education that we use lay terms and avoid medical jargon. While we're educating patients, it might be useful to let them know that research has shown that no more than 1 to 2 standard drinks per day is healthy for men, and no more than 1 per day is healthy for women. The initial recommendation we make depends largely on the audit score. If the audit is 20 or greater, our initial recommendation should be referral for specialty-based assessment and possibly treatment. If the audit score falls between 8 and 19, there's some other information we should gather. Has the patient had alcohol treatment in the past? Does alcohol dependence tend to run in the family? Does the patient have certain alcohol-sensitive medical conditions? Or do they take certain medications which are unsafe to take with alcohol? If the answer to any of those questions is yes, it's best to recommend abstinence. If the answer to those questions is no, then we can recommend those low-risk, safe drinking cutoffs. No more than 14 per week, or 4 in an occasion for men, and no more than 7 per week, or 3 in an occasion for women. And if the audit score is less than 8, then we can reinforce good, healthy drinking. Now, often patients will not accept our first recommendation. The strategy here is to support any positive change. So if a patient initially declines a referral, perhaps they're willing to try abstaining or cutting down on their own. If a patient is unwilling to stick to those low-risk drinking limits, perhaps they're willing to cut down some. And some patients, of course, will not be ready to change at all. Our job is to accept their decision and perhaps find openings for additional discussion in the future. If the patient is willing to accept a referral, there are several options to consider. Referral for professional treatment is best, and sometimes we need to help patients negotiate barriers around financing, childcare, and transportation. Sometimes patients may have a preference for certain treatment modalities. In general, it's best if alcohol-dependent individuals can get pharmacotherapy in addition to traditional talk therapies. Some patients will prefer to seek lay assistance, perhaps through Alcoholics Anonymous or Smart Recovery. Occasionally, patients will go to 1 or 2 meetings and feel like there's not a good fit. So in general, I recommend that patients try several different meetings before they come to final conclusions. For most patients, the plan will involve self-management. We can help patients set limits. How many days per week will they drink? What's the maximum number of standard drinks they'll have per day and per week? We might help patients fill in a weekly calendar. So for example, this male patient decided to limit the number of drinks to 4 on Friday, Saturday, and Sunday. This left 2 standard drinks during weekdays, and that adds up to no more than 14 drinks per week, putting this individual in the low-risk drinking category. We can also help patients recognize possible triggers, what might trigger them to drink more than these limits, and we can help them make plans to avoid those triggers or to manage them perhaps with substitute behaviors. For example, a patient who finds that stress may trigger more drinking, we can help them identify behaviors to engage in when they suffer from that stress. We can also help patients identify environmental factors that might trigger excessive drinking and help them avoid or change those environments. For example, patients may wish to empty their liquor cabinets to reduce their temptation. When we're helping patients set a plan, we always want to invite follow-up. It's nice if the follow-up can occur face-to-face, but if not, a phone call may be useful. In conducting follow-up, we want to assess how well the patient has implemented the plan. If not so well, has the patient lost some motivation to change? Might there be a need to modify the plan? If the patient is engaged in the plan, how effective is the plan? Might there be a need to modify the plan here as well? Some patients may be adhering to the plan, but not enjoying benefits. For example, a patient may be drinking less to improve their sense of energy. Are they enjoying that improved sense of energy? If not, do they need to further reduce their drinking limits? When some patients attempt to cut down, they recognize they have difficulty controlling their drinking. Might this be a symptom of alcohol dependence? Might this patient benefit from a referral for specialty-based alcohol assessment and possible treatment? So now we've covered quite a bit about alcohol screening, assessment, intervention, and referral. A remaining question is how all of these services can be integrated with cancer screening in busy clinical settings. One issue worth discussing is how do we bring up alcohol in busy clinical visits? One way to do that is after we recommend cancer screening. We can ask patients if they know about behaviors they can engage in to actually prevent cancer in the first place. We can make several typical recommendations about tobacco, sun exposure, etc. And then we can ask patients if they know that alcohol can increase their cancer risk. Then we can ask patients if they drink alcohol, and if so, we can begin the screen. At this point, I'm sure many of you are thinking these would be wonderful, worthwhile services to deliver, but do you possibly have the time to do all of this? If not, then here's where we get back to discussing the Wisconsin Initiative to Promote Healthy Lifestyle and WIFL's model of integrating alcohol screening and intervention into busy clinical practices. In WIFL clinics, typically patients complete a screen while they're in the waiting room. The receptionist hands them the screen and asks them to complete it before they see their providers. Typically, the medical assistant who checks vital signs reviews the written screen, and if the alcohol screening question is positive, then the medical assistant refers that patient to an on-site health educator who sees the patient preferably at that visit and delivers all appropriate assessment, intervention, and referral services. As you know, many experts recommend that we adopt a team approach so that we can actually deliver all of the preventive and chronic illness services that patients require. So the WIFL model includes expanding your health team with a dedicated health educator who can deliver all these alcohol-related services. In hospital settings and emergency departments, it's even easier. Health educators can simply introduce themselves to patients, start the screening, and deliver all appropriate services. WIFL has implemented this model in 31 clinical sites around Wisconsin. With our help, those clinics have screened over 117,000 patients and delivered over 26,000 interventions. Patients have indicated high satisfaction with the services. We've helped patients decrease their binge drinking by 20%. Plus, we've substantially decreased regular marijuana use and depression symptoms. Advantages of this model is that it can help your primary care setting meet many NCQA criteria for patient-centered medical homes. This model will also help you address 3 quality measures if you are a Medicare Accountable Care Organization. These services would generate healthcare cost savings for those ACOs. Also, this model would help systematically address Joint Commission quality measures on tobacco and alcohol screening and intervention. And of course, most of us are still working on a fee-for-service basis, and the reimbursement available in Wisconsin through Medicaid and many commercial payers can help you generate a small profit by delivering these services. So in summary, alcohol use is clearly an important cancer risk factor. It's great that we're all trying to make sure that patients are up to date with their cancer screenings, but we can do even better. Through alcohol screening and intervention, we can help prevent many cancers from starting. Experts have found that alcohol screening and intervention is actually more effective and saves more money than most other preventive services. We can deliver these services efficiently by having patients complete screens and assessments in writing. Of course, there's no way around it. Interventions, referrals, and follow-ups can take time, but if you don't have that time, adding a health educator to your healthcare team can allow you to deliver these wonderful prevention services. If you'd like any more information on this model, please visit the WIFL website at wiphl.org.
Well, thanks for joining me today for this educational presentation. I hope you're more convinced that it makes sense to integrate alcohol screening and intervention into routine cancer screening. If you'd like any more information, please consult the WIFL website at wiphl.org, and feel free to contact me at the University of Wisconsin School of Medicine and Public Health.